Thank you very much for inviting me here to speak on erector spinae plane block, future directions and remaining questions. And I feel very privileged to be part of this very important panel. I have a few disclosures, none of which will impact on my ability to deliver this talk. And here is a reminder of the hashtag if you decide you would like to tweet during this talk. So what am I going to cover? I'm going to cover what we know about the erector spinae plane block, what we don't know about ESP, questions that we need to answer, and what the future holds for ESP as far as I'm concerned. There is no doubt that ESP has formed part of this evolution of anesthetic techniques where we thought the tap block was the beginning of this explosion of fascial plane blocks, and then the ESP has come into the foreground now. So what do we know about it? Well, I'll tell you what we do know. We do know that the number of publications on the ESP have increased and gone through the roof. I've actually done a plot of the true number of publications per year, and they very much mirror this diagram we've got here in the background. So there have been a lot of publications on ESP. There's much enthusiasm and many indications have been discovered. Pretty much every area you can think about in the trunk and in the limbs has come up with a potential use for the erector spinae plane block. But despite this, there has been a divide. And what this has done, unfortunately, is divide the regional anesthesia masses into two very distinct groups, those that love ESP and those that don't love ESP. The real question is, why is this? What is it that people are afraid of or dislike about the ESP? I think there are a number of potential explanations. Could be that people are just fear change, the fact that it's too new, it's too novel. Maybe we don't really know where this role for this block lies. It could be the fact that there doesn't seem to be enough evidence yet, certainly with regards to the older techniques. Maybe the fact that the technique gives inconsistent results. Maybe people are just not familiar with how to site the block. Or maybe they're so used to having high success rates with things like brachial plexus blocks or with epidurals that the fear of failure with a technique that's inconsistent is putting them off. Maybe they just prefer alternatives, or maybe they feel troubled by the fact there is a variable sensory loss. You don't get a predictable cutaneous sensory loss. If we're talking about this, let's have a look at this in a bit more detail. So this study here took 12 volunteers in the sitting position and used 20 mils of 0.5% ropivacaine, and they noticed a loss of sensation in the posterior thorax only. Another study here. This was now 6 volunteers, again in the sitting position, this time with a higher volume of 30 milliliters of 0.375% ropivacaine, and they noticed a loss of sensation in the posterior and the lateral thorax. But there's one patient here, there's one volunteer number 6. In that volunteer, the needle went a little bit deeper than the standard ESP endpoint, possibly to where you'd be citing an MTP, and look, they got a much more extensive cutaneous loss of sensation, and maybe that's because they got an MTP type injection. What we can say from looking at this data is that blockade of the dorsal ramus or the posterior ramus seems very likely, and certainly if you zoom in and have a look at the anatomy here, you can see how injection just above the transverse process in close proximity to the dorsal ramus here, it makes sense that you would get cutaneous loss of sensation in the distribution of the dorsal ramus. Now, if I was considering marketing blocks, like I would do a drug, what might I say about a paravertebral block? What I might say was it provides effective pain relief. It's effective, it's relatively safe, perhaps not so simple, but it would come with a disclaimer. Caution, requires advanced skills, has a failure rate, may drop your blood pressure, etc., etc. Going right the way down to the fact that maybe you cannot take it with blood thinners. If I was to do the same now with the erector spinae plane block, I might say, you know what, it provides pretty good pain relief. It's easy to use or to site, and it requires basic skills, maintains your blood pressure, can be used with blood thinners, we think, and we can still insert it if the BMI is high. It's simple, it's safe, it's pretty effective, but the caution would be the analgesic effect may vary, and there's a very low risk of pneumothorax because we are aware of at least one case report of that being the case. So let's crack on with the main part of the presentation now. So what do we know about ESP blocks? We know that actually in some indications they work very well. Sometimes maybe not so well. Sometimes they probably work just enough. They're not as good as we'd like. It's very rare to get a dense neural blockade, and we do know that the evidence is inconsistent at the moment. We also know that dermatomal loss of sensation varies, but it is quite likely that you get a dorsal ramus block. Now, what's really important, and the focus of this talk, is what don't we know about the ESP? So we don't know whether it actually provides effective analgesia, and you will have heard lots of lectures about the different indications for this block already. We also don't know how it works. Does it work by paravertebral by proxy or some other route? We don't know what the optimal volume is, whether it's actually really safe with anticoagulation. Does it matter if you don't get that predictable cutaneous loss of sensation? And actually, does it have a role in modern regional anesthesia? So let's start off by talking about the mechanism of action. So broadly speaking, when you administer a local anesthetic, it can act on nerves in the injected plane, in the adjacent plane or tissues, or in distant planes or tissues via systemic absorption. So if you look at the erectospinal plane block, you imagine the needle comes in, you get the dorsal ramus. That kind of makes sense. I think we've confirmed that. We hope that you get the ventral ramus and by paravertebral block by proxy and maybe the sympathetics. And there's also the potential for you to get the lateral cutaneous branch, kind of like a serratus plane by proxy. But there has been some controversy about that because it may be the erectospinal muscle will prevent some of that lateral sped. So if you were to have a look at those two sort of those three things that we described, so nerves in the injected plane and in the adjacent plane and nerves at distance planes, you can actually see how for ESP it makes sense that actually if the dorsal ramus lies in the injected plane where it is, it may get that, and certainly by diffusion it could pass into the paravertebral space, but probably the systemic effect of local anesthetic with ESP blocks is less likely, certainly to explain a long-lasting effect of a drug like this, especially after a single shot block. So let's look at some of our cadaver studies. So this was the original description back in 2016. And what they looked at the cadaver study, what they described was spread of the dye in the vicinity of the dorsal and ventral rami. And then we went on to say this could be acting by paravertebral spread. But a lot of other studies have looked at a bit more detail. Here, this paper from 2018 comparing retrolaminar and erectospinal plane blocks. And whilst they did notice spread of the dye towards the ventral ramus, they did comment the amount of dye within the paravertebral space following both of these techniques seemed too small to allow for upward or downward flow. But again, this is macroscopic assessment. Another study, again from 2018, in fact, didn't even show local anesthetic going anywhere near the ventral rami. It only showed dorsal rami spread. And this now very nice review from 2020 by Ki Jin and by Kareem had a look at, summarize all of the Cadaver studies to date, and what it showed quite consistently was that the dorsal ramus was affected. Although there was some ventral ramus affected, it wasn't consistently that you got local anesthetic or, more importantly, dye within the paravertebral space. And they concluded that there was limited evidence of by proxy spread, and that there was variation within cadaver studies for many reasons. And actually, cadaveric studies may not relate to real life because of the impact of movement of tissues and fascial planes, the presence of organs, and also mechanical ventilation. But this paper came out very recently. This is something that's just come out in early 2021. This is now looking at a little bit more detail. They took 2 cadavers and performed bilateral ESP blocks at T5 using 20 milliliters of black dye. And they did a macroscopic anatomical dissection, but also a microscopic histological examination. And that's what makes this different. When they had a look, they noticed that there was dorsal spread between T2, T3 to T10, 11, plus spread 10 centimeters laterally at the biggest extent at the back. But watching, they looked at the ventral aspect, they noticed that you got paravertebral spread between T2 to T3 and T9 to T10. So this was evidence of paravertebral spread. But if you have a looked in a bit more detail, what they noticed was the dye diffused into the intercostal space, and it followed blood vessels associated with the dorsal ramus, showing a realistic path for getting local anesthetic into the paravertebral space. And this happened via the costotransverse foramen. You can see the image on the left here with the a blood vessel surrounded by dye, and an image on the right with both a blood vessel and a nerve surrounded by dye. And if you have a look at this this video I've mocked up over here, you can see if you follow the blood vessel and the dorsal ramus, you can see a pathway through via the costotransverse ligament into the paravertebral space if you simply follow that blood vessel. And that could be potentially how the local anesthetic might get here. Now, this study was even more recent. This has come out, published ahead of print in Rapim in May 2021, took 11 embalmed cadavers, and they did something really fascinating. They did micro CT of the thoracic paravertebral space. Now, we all know the classic appearance of the paravertebral space when we think about schematic diagrams, and it's something like this, where you've got the internal intercostal membrane and the superior costotransverse ligament forming a barrier to the paravertebral space. Actually, what this study's done is confirmed that this is an outdated view. And in fact, if you look at this colorized micro CT here, you'll see that you've got the internal intercostal membrane and the superior costotransverse ligament, but there are two very obvious slits or areas where local anesthetic or dye can pass and get into the ventral ramus, into the intercostal nerve, into the paravertebral space. The green colored area behind the superior costotransverse ligament is the retro superior costotransverse ligament space. What's beautiful is this wonderful micro CT slice here. And if I colorize it for you, you'll see the purple represents the superior costotransverse ligament and the brown is the internal intercostal membrane. And you can see there are two slits here through which potential routes for local anesthetic or dye can access from posterior to the paravertebral space into the paravertebral space. So this is really interesting. What they've done here is they said, look, the superior costotransverse ligament incompletely forms the posterior wall of the paravertebral space, and the retro superior costotransverse ligament space contains the dorsal ramus and the proximal ventral ramus. It communicates with the paravertebral space via these slits, but also with the erector spinae plane and the intervertebral foramen. And if you look at this now, side-by-side comparison of an ultrasound image, a micro CT and a schematic, you can understand potentially how local anesthetic within the erector spinae plane that has access to that retro superior costotransverse ligament space may actually act by paravertebral by proxy. So in cadavers, if injectate can access that space, it can access the paravertebral space. But what about living subjects? So let's have a look at some imaging studies in the living. So this study from 2018, we took 30 milliliters of local anesthetic and contrast and showed in the erector spinae plane and showed that it went to the paravertebral space, to the intervertebral foramina, to the epidural, and even to the intercostal spaces. So this was in a live human. This is another study now from 2019. They took 13 milliliters of contrast and phenol and noticed that local anesthetic, when it was placed in the erector spinae plane, got to the intervertebral foramina and the paravertebral space. And this other study from 2019 here shows 25 milliliters of local anesthetic when injected as an erector spinae plane, went to the retrolaminar space, to the paravertebral space, and to the epidural space. So certainly there is evidence in living subjects that you get a ventral spread towards the paravertebral space, the intervertebral foramina, and to the epidural space. Does this explain how erector spinae plane blocks have their analgesic effect? Maybe. What about volume of injectate? So again, now this is another paper from 2018, again from Adhikari. They took 3 cadavers and they did erector spinae plane blocks and retrolaminar blocks on each of them, and they injected 20 milliliters of radiocontrast at T5 and then did an MRI scan followed by dissection. And they noticed that you got paravertebral spread with 20 milliliters at 2 to 3 spinal levels. This is a really interesting study here now. So they got 7 cadavers, did bilateral erector spinae plane blocks, and they compared 10 milliliters versus 30 milliliters. But immediately after performing the block, they did endoscopy and then followed that with dissection. And actually what they noticed was with the 10 milliliter injections, you did not get paravertebral spread. You did stain the superior costotransverse ligament, but you did not get paravertebral spread. With all of the 30 milliliter injections, you did do, and again, you got 3 spinal levels, but the higher volume was associated with more posterolateral spread as opposed to more vertebral levels. So the real question is, if in the previous study we were using 20 mils and got 2 to 3 levels, and if you use 30 milliliters here and got 2 to 3 levels, is it worthwhile increasing the volume? Well, what about this? This is a study that is yet to be published, but was presented by Jeff Gadsden and his team at ASRA this year. They took 2 cadavers and did lumbar ESP blocks. So they did 10 milliliters plus 10 milliliters plus 10 milliliters in a sequential manner and used with contrast and dye. And then they did real-time fluoroscopy followed by dissection, and actually compared this to surgical infiltration on the contralateral side. And what they noticed was as they increased the volume of injectate, and also as they waited a little bit more time, you increased the number of levels that you blocked, with 10 mils giving you 2 levels and 30 mils giving you 4 levels of spread. But importantly, when they did a lumbar ESP, they did not get any spread to the paravertebral space or to the ventral rami. So what is the ideal volume? Is it somewhere between 20 to 30 mils? Clearly 10 mils doesn't seem to spread, but 30 mils maybe. And is it the same for the thoracic ESP and the lumbar ESP? I suspect it probably isn't. The next question is it safe to perform ESP blocks in the presence of anticoagulation? So we've got the American Society and the European Society of Regional Anesthesia and the Association of Anaesthetists that have guidelines, but they're not block specific. And the Canadian Practice Advisory, which is mainly a consensus opinion based upon a review of the evidence, have stated they think that the ESP block has a low risk of bleeding. And we've got a few case studies here now. So this is Sanjeev Adhikari again, and he presents here patients who had left ventricular assist device insertion, who were all receiving systemic heparinization. And in 4 cases, they had to cite rescue ESP catheters for analgesia. And in 1 case, based upon the success of the previous 4 cases, they did a preoperative ESP catheter, and they all got good analgesia without complications during catheter insertion or removal. The reason I talked about this was I thought this is very cool. This is another case here now where the patient who had a post-operative lung transplant was in severe pain post-extubation, but also developed atrial fibrillation requiring systemic anticoagulation and got progressively worse saturations and increased pain score. These guys cited a continuous ESP catheter without interrupting heparinization. And you'll see from this graph here, the oxygen saturations improved, the pain score reduced. So that is definitely a positive outcome of using ESPs in anticoagulated patients. So it appears to be safe to use ESP in the presence of anticoagulation, but as always, as you can see from the background image here, there are blood vessels there. It's always worthwhile having that risk-benefit discussion and taking usual precautions as you would do when performing any block. Now, what about sensory loss? Does the absence of the variability of a sensory loss or cutaneous sensory loss matter? So would you consider a block failed if there was no sensory loss, but analgesia and opioid reduction was still evident? The patient derives a benefit, in that it's an improvement with pain scores and opioids. And if they develop and display an improvement in patient-reported outcome measures and quality of recovery. So I guess what I'm asking is sensory loss a marker of success with ESP? I would argue it isn't, because many of the clinical studies that have shown a clinical benefit to erectospinal plain block have not demonstrated cutaneous sensory loss. So why might you get inconsistent sensory loss? Well, we know that anatomic cutaneous innervation is complex. And there is also situations where you get overlapping innervation crossing the midline. You've got variations between individuals. And actually, when our local anesthetic, if it's injected in the erectospinal plane and then diffuses across the paravertebral space, the concentration available to act to the paravertebral space is much less than the concentration injected. And that may well generate a differential block where you preferentially block C fibers as opposed to A delta fibers, or vice versa. It's also depends, we're relying on the fact that people are injecting in the correct manner, and we're hoping that people inject in the right space in order to get a nice spread. And but we know that actually not everybody does inject in the right space, and sometimes you get intramuscular injections, and this will affect the quality of spread that you get. So that may be why that sensory loss is inconsistent. The next question to ask is there a role for regional anesthesia in the future? So does modern regional anesthesia have a role for the erectospinal plain block? Well, I think the answer is it does, mainly because it increases access to regional anesthesia. To the uninitiated, regional anesthesia can seem daunting. Now, the concept of the erectospinal plain block is simple. It's a safe and a superficial block. It's considered by many to be an entry-level block, and it may be that actually you increase the access of patients to regional anesthesia because it can be performed in the emergency department by emergency physicians and in the ICU. And also, you can use the ESP as a stepping stone in terms of skill progression. You can start off learning how to do an erector spinae plane block. When you get more confident, you can then advance your needle tip a bit further and perform an MTP or an intertransverse plane block. Then when you get really good, you can take the next leap and then perform a paravertebral block. So it's useful in its own right, but also in terms of skill progression. But we do also need alternatives to the paravertebral block. And the reason for that is there are some situations where you can't cite a paravertebral or an epidural. And there may be some specialties where, because of anticoagulation, you are not in a position to cite those blocks. Also, you may want to avoid the sympathectomy or the hypertension you can get with epidurals or some other side effects. Maybe those techniques that you performed initially fail and you need a rescue technique. Or you may be unable to perform an epidural or a paravertebral because of patient positioning or the lack of a skilled practitioner or postoperative monitoring. So where do I think erector spinae plane blocks have a role? Well, I think the no-brainer here really is spine surgery. And you'll see 2019, 2020, 2021, I've just selected a few of the papers that are showing that there is a benefit for using erector spinae plane blocks in simple and complex spinal surgery. So I think ESP and spine seem like a good fit. So let's move on to the future and future directions. I think what we really do need is randomized controlled trials using ESP, but also using multimodal analgesia and active comparators. We need to know, does erector spinae plane block provide effective analgesia at all? It'd be really useful to know how it fares when we look at patient-reported outcome measures like quality of recovery, and we look at the minimum clinically important difference. We should identify which surgery has the best fit. I've alluded to spine surgery. I think that may be a role. But if we know if it's not perfect, is it good enough? And in which situations is it good enough? The other thing we need to talk about is success. How do we improve success? How do we maintain consistency? I think we need to identify the ideal endpoint and determine the optimal volume. There's still some ambiguity about that. And also, does it matter if we inject from a cephalad to caudad direction or caudad to cephalad? Does it make a difference if we do a parasagittal or paramedian sagittal scan, a needle in plane or out of plane? Is an out of plane more preferable? Or should we be doing a transverse in plane or out of plane to make sure we can carefully elucidate that we're not injecting intramuscularly? We also need to know the optimal mass of local anesthetic to inject. Now, is it ideal for us to inject slightly deep to the erector spinae plane, or to create an artificial conduit, such as doing this supercharged MTP that I've talked about? We also don't know what the optimal catheter regime is. We suspect intermittent bolus is the way forward, but it'd be important to clarify that. I think Jeff Gadsden in his editorial puts it very nicely. He says we need to spend less effort on celebrating unique applications and instead focus on rigorously clarifying how this block actually works so that we can apply it more consistently in our practice. So I think our takeaway points are the erector spinae plane block is here to stay. It's not going anywhere. It isn't perfect. It probably works in a number of ways, including potentially paravertebral by proxy. It may be good enough for many indications. We definitely don't need any more case reports, but we do need more randomized controlled trials because what we don't know is much more than what we do know. That's all I have to say. Many thanks. I hope you've enjoyed this lecture.